I'm going to talk about contrast echocardiography, tips, tricks, and illustrative cases. This is a request from one of the fellows who mentioned that I hadn't spoken about contrast, at least formally at our echo rounds. As many of you have probably heard me speak of contrast before, so some of this may be a little bit repetitive, or you've heard some of these things before, but I think it's always useful to hear things again, just to focus on certain points. I have spoken for Lantheus Medical Imaging in the past, nothing recent, and that's my disclosure. So these are the objectives that were supplied by Dr. Chow, who sent out the notice for the rounds today. So to provide a basic review, just an update for folks, for any novice users, discuss some of the practical applications, and then showcase some illustrative cases and some of the use for ultrasound-enhancing agents beyond left ventricular opacification. So I always start off with a summary slide with regards to some of the challenges that we have and where ultrasound-enhancing agents can be helpful. And I think we've all seen that despite marked improvements in technology, the suboptimal echo still remains a very challenging problem. You know, we hear from all the major vendors that image quality is improving, all these advances to see the walls better and to make the images look nicer. And, you know, despite that, day to day in the echo lab, you know, I think the number of TDS or technically difficult studies continues to be a problem. So some days it seems to be almost every single patient. I know the sonographers feel the same way. And then this is coupled with, you know, an increasing demand for us to be more quantitative with regards to our LVEF assessments. And in many aspects, a qualitative LVEF range, for example, is not going to suffice. And the most striking example of this is Cardio-Oncology, where, you know, despite the fact that we know that the LV systolic function is normal, the clinicians and the referring physicians really want a quantitative assessment, and they want it to be as accurate as possible. And because of that, you know, contrast still is an important tool for us to overcome some of these limitations. And this is an example of a TDS echo shown on the right in apical 4 and apical 2 chamber view, where you really can see that endocardium. You get the sense that overall LVEF is within normal limits. Certainly couldn't rule out any focal regional wall motion abnormalities, at least based on these images. So ultrasound enhancing agents or microbubbles, the structure of them is that they're small. They're about anywhere from probably 1 to 3 microns, 1 to 4 microns in diameter. So they're smaller than red cells. They have an outer shell and an inner gas. The shell could be a lipid shell. It could be albumin. It could be other types of materials. And the inner gas, the first generation microbubbles had nitrogen in them, so sort of air-filled bubbles. But all the second and further generation microbubbles have these heavy gases, these high molecular weight perfluorocarbons that have a low solubility and high persistence, and that results in instability of the microbubbles. And because the microbubbles are smaller than red cells, they traverse the capillaries in the lungs, as shown in the loop on the right, where ultrasound-enhancing agents are injected intravenously. They go into the right side, right atrium, right ventricle, cross freely through the pulmonary circulation, and then enter the left atrium through the pulmonary veins, and then slowly opacifies the LV in this patient with moderate to severe LV systolic dysfunction. And that's as opposed to the agitated saline contrast that we use to detect interatrial or transpulmonary shunts, which are large and fragile and do not cross the pulmonary circulation unless there's a connection either through the heart or through the lungs. And these microbubbles will oscillate when they're hit by ultrasound. They'll reflect the waves, and the reflected waves are processed by our systems and generates this very bright signal within the cavity. So essentially it's a blood pool agent. And because of the size of the microbubbles, they remain purely intravascular during their transit in the body and do not escape unless there's an actual connection. So the endothelial barrier prevents these bubbles from getting out into the interstitium outside the vessels unless there's an actual connection, a true connection which blood can also pass through. So we're lucky enough to have 3 agents that are approved for use in Canada. Only 2 are really marketed and available, and that's Definity from Lantheus Medical Imaging and SonoView from Bracco Diagnostics. They're all very similar, different shells, different gases, but the diameter is essentially the same. And you can see the vast majority of the bubbles are less than 10 microns, but there's a very small percentage that are greater than 10 microns, and these are the potential bubbles that can lodge temporarily in capillaries, and that relates to some of the potential, or at least concern for side effects, which have been largely dissipated. So, we use ultrasound-enhancing agents really in our lab and many labs across Ontario and Canada. Although I would say that there are still labs that do not use ultrasound-enhancing agents, and it really, it's something that all labs should consider and should implement in their armamentarium for these difficult studies, which we still see, and it's a marker of quality. So, for me, a lab that does not use ultrasound-enhancing agents on a routine basis I really can't put it into that high quality echo lab category. So here's an apical 4, an apical 2, and actually you can't really. Oops, I apologize. Go back. Yeah, so you can't. The only reason you can tell this is an apical 4 and apical 2 is because the sonographer has been kind enough to put these diagrams here that to let the reader know, because without those you'd probably be guessing as to what view you're looking at. And the reason I show this is because I've had people ask me, is there ever a time where images are so bad that it's of no use to give ultrasound-enhancing agents? And my response to that is sometimes you just don't know until you try, and we should try. So there's no excuse for not trying ultrasound-enhancing agents. I guess if you can't see the heart at all, maybe in that case, but even then, sometimes administering an ultrasound-enhancing agent might help you at least find the heart sometimes where it's difficult to find it. So here's a patient where you're not sure if it will help, and this patient had, and these are the same images from the very same patient that had, this is a more zoom view, apical 4 on the left, apical 2 on the right, and here actually you can see quite good opacification of the left ventricle, and you can trace it. You do a quantitative LVEF, and you can see this patient's LVEF is not normal. It's probably mildly reduced, probably in that 45 plus or minus 5% range, but you can easily quantify this by tracing for Simpson's biplane. With regards to optimizing the images for LV opacification, the most recent guidelines from the American Society of Echocardiography in 2018 really focus on the contrast-specific presets, and this is a table from the guidelines with all the major vendors, some of their systems, and what's available from a contrast-specific imaging aspect. Worthwhile to take a look at it if you want to see what's available on your systems or potentially available on your systems. And we've always appeal to the major vendors that contrast-specific presets should be a default setting within your systems. You shouldn't have to ask for it as an additional add-on. It should be on every standard purchase of echo equipment. And the one specific contrast protocol or imaging modality that you should really look at is this VLMI, the very low mechanical index. And these are essentially the real-time perfusion imaging techniques that have been developed to look at myocardial perfusion. They end up being very, very good for LV opacification for the most part, depending on the overall images. So, for example, with the Philips system, they have this power modulation angiography, a combination of amplitude and pulse inversion, these settings are specifically developed to amplify or enhance signal from the microbubbles while suppressing tissue signal. So ideally, you create that nice interface between a really dark myocardium and a bright LV cavity. So here's a couple of examples, apical 4 and apical 2. You can see the epicardium quite well, although you can't see the epicardium on the apical 2 chamber view. You can't see that anterior wall, but you can see you can't see the endocardium on any of the views. And with the addition of an ultrasound-enhancing agent, you can see it's the LV cavity is nice and bright and white. The myocardium is relatively dark. It's not completely dark. It's relatively dark. Bubbles do get it within the myocardium, but there's enough contrast between the cavity and the endocardium that you can trace it. You can look at the walls. You can see a bit of the myocardium, so you can look at myocardial thickening as well. So this is an example of the utility of ultrasound-enhancing agents for LVEF quantification. This is a cardio-oncology case, so non-enhanced images on the left with the apical 4 and the apical 2. Not bad endocardial definition, actually pretty good enough for a qualitative LVEF, knowing it looks like it's normal, probably between 55 and 60%, maybe slightly above 60%. The challenging areas typically end up being the apex. And you can see you can't see the endocardial, you can't see the endocardium well at the apex, both the apical 4 and the apical 2. And then that anterior wall here, the apical 2 and the lateral wall on the apical 4 tend to be the more challenging walls. But with the addition of an ultrasound-enhancing agents, and this is with the VLMI for the Philips system, you can see how beautiful the opacification is. You can actually see some microbubbles within the myocardium as well. But this will be very easily traceable. You can get LV volumes in the apical 4 and apical 2 and provide that LVEF quantification that the oncologist needs to know that he can go ahead and give that chemotherapeutic agent. In terms of optimizing your LV opacification, I've talked about this before, particularly with our sonographers. The very first injection, I call it, there's a golden washing phase that I love to see. And here, there's just a couple of frames after injection of ultrasound-enhancing agent, in this case, Definity. You'll see it pacify the right atrium, right ventricle, get into the left ventricle here. You can see it hasn't really quite gone into the myocardium. The myocardium is nice and dark. You can see there's that initial slow bolus phase. There's a bit of attenuation in the base. But as you wait a little bit, you get that sweet spot, the bottom two images, where there's some contrast within the myocardium, but it's not overpowering. It's not overly bright. You can still see the borders quite well. And on top of that, the concentration now has leveled off. It's dropped a little bit, and you don't have that basal attenuation. You can see right down to the base of the LV walls here, the base of the interseptum, base of that lateral wall, base of the same here. You can really trace all the way down to the annulus to get a really good quantification of LVEF. And you can see all the walls, both systole and diastole. You've been able to not foreshorten the apex. And this will give you a very accurate quantification of LVEF, probably the most accurate that you can get from 2D echocardiography. And here's another patient, so you can see there's some dyssynergy here, maybe a conduction delay or a pace rhythm. But you want to have that dark myocardium and that bright cavity. And the image on the right here, now you can see full opacification of the myocardium. So this is contrast perfusion within the myocardium. Here it's a bit more difficult. You probably still do it, but definitely more difficult to trace, especially when you have this potential translation of that anterolateral wall. But here it's a little bit easier. So this is the type of image that you want to get for tracing and for assessment of wall motion as well. And sometimes in order to do that, it's worthwhile to use flash imaging. So flash imaging is the machine settings where you deliver several frames of high power ultrasound. So usually anywhere from mechanical units of 0.7 all the way to above 1. You deliver it at frame rate, and you transiently destroy the microbubbles within the ultrasound beam. You clear the myocardium, and you clear a little bit of the LV cavity as well, but the LV cavity fills very, very quickly. And then it allows you to have that nice dark myocardium-bright cavity. And a couple of beats after the flash, you'll be able to, maybe 2 to 3 beats after the flash, you'll be able to trace as well. So instead of having to trace this image on the left, you get to trace this image on the right if you freeze MDAS and SSD. So the flash imaging is a nice tool to have. I think you have to be a bit strategic in terms of flash. You have to decide whether to flash and when to flash. So here's a case where you see the flash that destroys the microbubbles, but even before the flash, you haven't fully opacified the LV. They're still swollen within the LV. So I think they flashed a little bit too early, and you want to have that full opacification, because what happens is, like, you destroy the bubbles within the LV cavity before it's opacified fully, and you create even less concentration of microbubbles, and you still have that non-opacified LV, and it's going to be difficult to trace in this particular setting. So you have to know whether to flash. Sometimes you don't have to flash, and you have to know when to flash. So here's an example where you probably didn't need to flash. You have a nice dark myocardium, and you probably don't need to flash in this particular circumstance, and just make it more difficult for you to trace, because you destroy the bubbles, and you have to wait for it to do so. Here's a case where this is that really bright myocardium here, and this is a case where it's probably worthwhile delivering a couple of frames of ultrasound to destroy the bubbles within the myocardium to get a better interface, and you be able to trace that, and that's LV cell function a little bit better. So we've all used ultrasound-enhancing agents to assess for LV thrombus, LV clots, and this is an example I've shown many times in many different conferences, and some of you may have seen this before. But here's a non-contrast apical 4 on the left, and this is what a thrombus looks like on contrast imaging. It's a dark. It doesn't take up contrast. It's attached to a wall that's not moving, and you can see it's going in and out of thing here. What's more challenging is in the setting of a laminated or a layered apical thrombus. Here's a patient with an ischemic cardiomyopathy, apical aneurysm. Really can't see anything with the non-contrast enhanced images, and with the VLMI imaging, it's a little bit easier to look at that layered thrombus. This is a layered thrombus, and the clues here really is you get this layering of this very dark material. So in contrast imaging, once you wait long enough, there's always some bubbles within the myocardium, and then in the absence of, so you have the really dark layer, and so if you wait long enough, especially with the newer contrast-specific presets, you should get bubbles within the myocardium. What I was saying was that in the absence of perfusion in the setting of a scar, usually that scar is actually fairly bright as well. So it would be unusual for scar to be this dark, even with contrast-specific presets. And you also want to see that change in the contour of the left ventricle, where there's a little bit of separation. Here it's actually pretty smooth. This is actually quite a nice layered thrombus. And if you're not sure from this view here, then angling a little bit and getting something like this to actually scan through the entire apex might help you find that layered thrombus. Having said that, a clinician might tell you that it may not make as much of a difference, because a lot of times you'll see layered thrombi, and depending on clinical factors, whether or not the patient can tolerate anticoagulation, we might not necessarily anticoagulate. We don't know if anticoagulation of these very thin layered thrombi make a difference. Maybe something worthwhile for future studies. Okay, so here's another case of a very focal apical aneurysm, and when you have these focal apical aneurysms, because of stasis of blood flow. Remember, I told you that these microbubbles, these ultrasound-enhancing agents, are blood flow tracers. They're blood pool agents. They go wherever red cells go. If there's very stagnant or low flow in very focal apical aneurysms, it's very difficult to opacify these with contrast. So what you have to do is you have to you have to drop the depth, focus only on that apex, and then you have to give enough ultra-enhancing agents to essentially create attenuation at the base, but at least for pacifying the apex, you might have to drop that mechanical index more so that you destroy less bubbles, create less swirling. And here, you can see that the contrast hasn't quite filled that focal apical aneurysm. And you're not sure if there's a thrombus here, but just injecting more contrast, waiting a little bit longer, maybe reducing the mechanical index, putting the focus all the way up to the apex, as you see here. You can actually see there's a nice focal and layered apical thrombus within this very focal dyskinetic apical aneurysm. So because of its ability to pacify the left ventricle and to help us assess regional wall motion abnormalities, ultra-enhancing agents are particularly of use for stress echocardiography. And our use of ultra-enhancing agents for stress echo is probably about at least twice that of our rate of use for rest echo. So here's a patient with chest pain who comes for stress echocardiography, and this is the apical 4 chamber view at rest. This is the apical 2 chamber view the apical 4 chamber view at stress. Have you take a look at that and see if you think there's any inducible wall motion abnormality. Here's the apical 4 on the left, the apical 2 on the right, the apical 3 on the left at rest, the apical 3 with stress on the right. And this is supine bicycle stress echo. So this is actually during peak stress. So the question is, do you think it's a normal study? Do you think there's LV territory ischemia? Do you think that there's RC ischemia or circumflex ischemia, or do you think it's multi-territory or left main stenosis? And if you go back, let's go forward again. So, to my eye, I don't see any obvious regional wall motion abnormalities or thickening, but there's something unusual about the apex where maybe there's some tardikinesis. It doesn't quite, it seems to come in, but comes in a little bit late, or there's a bit of dyssynergy of that apex. So you wonder if patients developed a bundle branch block, for example, during stress, that sometimes that can cause these wall motion abnormalities, the absence of wall thickening abnormalities. And here the same with the apical 2, it just doesn't seem to have that same symmetrical contractility, but it seems to be coming in reasonably well. So whether you want to call possible elevated territory ischemia, apical ischemia, or normal, or you're not sure. So this patient actually had contrast with stress. This was actually part of a trial that we did. We were a participant with SonoView, and the patient actually had contrast and a non-contrast stress echo and a contrast stress echo. So they had both. And actually the apical 4 chamber view, rest on the left, stress on the right, and as you can see, the apex is better visualized with the use of ultra-enhancing agents. And with that, you can actually see focal hypokinesis of the apex. Apical 2 on the left, apical 2 at rest on the left, and apical 2 with stress on the right. And once again, you probably still have that tardikinesis, but on top of the tardikinesis, you also have that focal hypokinesis of the distal anterior wall and the LV apex. And the same for the 3 chamber view. Here you can actually see very focal apical hypokinesis, almost akinesis, with stress on the apical 3 chamber view. And the patient went on to have an angiogram, and this is left main. Here's an LAD. And you can actually see there's a fairly tight, probably 70-80+% stenosis of the proximal LAD. Surprising that you didn't have more extensive wall motion abnormalities in this setting. And from the stress echo standpoint, you probably would have suggested a mid or a distal LAD stenosis, but in this setting was reflective of a more proximal LAD stenosis. Here's another view. This is the Echocardiography, and you can see the fairly complex proximal to mid LAD stenosis. And the right corner view is normal. I'm just going to touch briefly on some of the safety aspects. So, this is just a table looking at the different risks of some of the routine things that we do on a regular basis in cardiology, such as exercise stress testing, disease stress testing, use of contrast agents, ion contrast agents for angiography or for CT contrast, for example, and diagnostic cardiac catheterization. These are the risks we generally quote to patients. These are the more significant risks. For example, cath is 1 in 500 to 1 in 1,000 of significant life-threatening complications, such as a death, myocardial infarction, arrhythmia, stroke, vascular complication, or contrast reaction, for example. And the use of these agents actually compare quite well. The risk of an anaphylactoid reaction is 1 in 10,000 for the literature, and something even worse than that, kind of a severe fatal reaction is 1 in 500,000. So I usually quote about 1 in 10,000 risk to patients before they consent for use of these ultra-enhancing agents in our lab. There was some concerns, a number I mentioned very early on, that a very small fraction of commercially available ultrasound-enhancing agents are greater than 10 microns in diameter, and theoretically can transiently plug the capillaries. And so we know a small proportion get trapped by the pulmonary capillaries. The retention fraction is probably around 1% or so, and they're transiently lodged, but they dislodge within 5 to 10 minutes. And the way they dislodge is that they slowly degas over time. Is one of the ways how bubbles are cleared through the circulation. So there's this theoretical risk of these very, very small percentage of larger bubbles that are not filtered through the lungs to get to the arterial circulation and transiently cause a plugging within, let's say, the capillaries in the brain, for example. And probably one of the reasons why patients even get agitated saline contrast, especially if they have a large right to left shunt, they have congenital heart disease, can develop some neurological symptoms with contrast agents. So you have to be very careful about using it in these patients. For example, patients with a large atrial septal defect, for example, which we generally don't necessarily need to use agitated saline with. But that's the concern with the use of these agents, that they transiently plug the arterial circulation. Having said that, the studies have shown that the risks of use with a patent foraminal valley is extremely low to zero, and because of that, they removed the aspects of a PFO from the contraindications from the product monograph label, at least in the US. I don't think they've done it yet in Canada, but for us, a PFO or even a small atrial septal defect is not a contraindication for absent saline contrast. For ultrasound-enhancing agents, sorry, for microbubble contrast. Okay. Just a plug for the use of contrast agents for Doppler enhancement. So here's a patient with aortic stenosis, very, very faint profile of the aortic valve VTI, the continuous wave Doppler. And we generally ask the sonographers if they're going to use Doppler enhancement with contrast agents, do it at the end of the study after LV opacification. And actually, the concentration of microbubbles that you need for Doppler enhancement is extremely low. It's like a fraction of what we need for full LV opacification. And if you give too much contrast when you're trying to use Doppler enhancement, you get this blooming artifact and likely an overestimation of the velocities and the gradients with ultrasound enhancement. And you really want to wait till there's just a small amount and you don't get good opacification of the left ventricle. And you want to make sure you want to reduce those Doppler gains down so that it's completely black in the background and you create this crisp interface. You definitely don't want to measure the fuzz. You want to really get around tight for the spectral profile. And that's the same for tricuspid regurgitation enhancement. So that was AS Doppler enhancement. This is TR, or tricuspid regurgitation Doppler enhancement, for RVSP assessment to get that pressure gradient for the TR jet. So here's a CW through this trace tricuspid regurgitation on the apical 4 chamber view. you get a faint signal. With this patient here, looks like atrial fibrillation. You get this variable R interval. Here you can see pretty nice profiles, but the sonographers nicely drop the Doppler gains down to create this crisp envelope, and you don't get a blooming artifact. You can so let's talk about some of the more advanced uses for ultrasound enhancing agents in your echo labs. I mentioned earlier that these agents don't get into places where red cells don't get into. So here's a patient with a moderate to large circumferential pericardial effusion. There's a bit of RA inversion here. You wonder about a bit of subtle early RV diastolic inversion in the subclassic view. And this is a patient of mine actually who had this pericardial effusion come up, minimally symptomatic, thankfully, it's relatively soon after placement of an ICD. You see the ICD wire here in the RV apex. And the big question is always, whether or not there's a perforation. And sometimes it's really difficult to tell on any kind of imaging technique. Sometimes people use CT to help define that, but it's very difficult to know for sure where that lead is, if it's gone all the way through. And even if it hasn't gone all the way through, is it partially through and there's a connection. And studies have shown that you can use ultrasound enhancing agents to see if there's a connection. And some of you may have seen some of these images before. So this is subclassic view on the left. This is an apical, probably fortune view on the right. And if you're pretty astute, so you can see that with injection of, in this case, the affinity contrast agent, you can see the microbubbles are in the pericardial space. And we use this to look at settings where there's a perforation of the cardiac chambers and the pericardial effusion. For example, post MI LV rupture, for example, or after a complex PCI where the wires perforated the coronary artery. So you can use it to see if there's a connection and ongoing leak. So if the microbubbles have ended up after injection of enhancing agents, then you know that blood is also going out within the pericardial space. Here's a patient post-bioprosthetic aortic valve replacement with a VSD patch for complicated infective endocarditis. This is the post-op transthoracic echo. You can see this echo-free space here that's anterior to the aortic annulus and the aortic root. And you can see here in the short axis images, it's a little bit more laterally displaced, kind of anterolateral to the aortic annulus. You're trying to figure out whether or not there's any flow, any connection from either the root or the LVOT into this cavity. And with color Doppler, it's really, really difficult to say. So, a blood pool agent, such as ultrasound enhancing agents, microbubbles, you can rarely tell whether or not there's a connection. And to do this, ideally, I'll go back a little bit, you should inject during imaging, so you can actually track the microbubbles, see them traverse through the myocardium to figure out whether or not there is a connection and where that connection is, at what level, and it's related to timing. So it's almost like a first pass imaging. So we've injected intravenously, opacify the right side RV, LV into the root, and you can see this cavity fully opacifies after injection of ultrasound enhancing agents. And I'll let it play again. You see the timing occurs really just after opacification of the aortic root. So the connection is actually at the root level or just at the annular level above the aortic annulus. So let's just let that play again. This example I showed at the contrast workshop at CSC for those who attended those workshops. You can actually see the connection. It almost looks like the connection is right here. You can figure out the timing. If Bob Howard is on the line, he always talks about looking at with saline contrast, see if you can look at the timing and where the connections are with regards to PFO detection for saline contrast. This is very similar for ultrasound enhancing agents. Okay, one more time, just for effect. Right here. Um, because it's a blood pool agent, you can also look at imaging vascular structures. So there have been several studies that have used it in looking at the aortic root, ascending aorta, aortic arch, even in the abdomen as well. And there's a patient with Marfan syndrome. You can see the dilatation of the aortic root, but so far preservation of the sinotubular junction, or reasonable preservation of sinotubular junction. But then when you go to the suprasternal imaging, there's this linear density here within the aortic arch, which is concerning for a dissection. Unfortunately, the color Doppler imaging doesn't really help with any differential flow. So this is a circumstance where you could use contrast agents. The same settings that you use for all the classification, you can see the mechanical input down to 0.18 in the top right-hand corner. And once again, it's first pass imaging. This is the RPA after intravenous injection. You can see venous. I'll go back one more. So just as you time it here, RPA here, probably a nominate vein coming through here. A bit of contrast in the vein in the RPA here, crossing over to the left, and then you can see the pacification of that aortic root. It's probably shadowing from clavicle or rib over here. If you're nice even opacification, and the timing here makes a difference. Just if you look at differential flow, but here it looks like there's fairly homogeneous, consistent classification of that aortic arch. It's starting to fill now, and it fills consistently throughout. It's probably an artifact that you saw with the previous imaging. Nice full opacification here of the arch. We've actually used this. I didn't show an example, but we've actually used ultrasound-enhancing agents in transesophageal echocardiography to look at morphology and functional characterization aortic syndromes in our lab. And this is just one study by Agricola and colleagues that looked at 66 patients with suspected acute aortic syndrome with standard T versus CT angiography versus contrast T. And in this study, contrast T was superior to regular non-contrast T in the visualization of the false lumen entry tear, and correctly diagnosed an intramural hematoma as well, so correlated better with CT angiography. So in that setting where perhaps the patient has renal insufficiency and you don't want to use CT angiography, if you're doing the T, then consider use of contrast, depending on what you're seeing and whether or not they can help you with differentiating acute aortic syndromes. I'm going to finish off with some other novel or non-LVO applications for ultrasound-enhancing agents. And this is part of the 2018 guidelines from the ASC. So ultrasound-enhancement can be considered doing T when the left atrial appendage has significant spontaneous contrast or cannot be adequately visualized, or contrast with VLMI, the very low mechanical index imaging, could be used in the differential diagnosis of cardiac masses to help assess vascularity. So whether or not there's any vascularity or perfusion within the mass, signifying a potential a tissue-based mass, such as a malignancy or a cancer, versus a thrombus, which should not be vascular. So here's an example, pre-cardioversion. You can see the patient's in atrial fibrillation, a rapid irregular rhythm, and this is a left atrial appendage view, a long axis, a short axis on the right, and there's an echo density that's sitting in the os of the left atrial appendage. Difficult to know if it's attached anywhere. You can see both on in two orthogonal views. And here, the question is this a thrombus or is it an artifact? And we certainly do see lots of artifacts within the left atrial appendage. And sometimes you will see pectinate muscles as well that can be confusing, these ridges that are within the left atrial appendage. And here's probably not a pectinate muscle, but the question is thrombus or artifact. It is it is challenging to use contrast um, in the setting of TE, in part because the contrast specific presets that are available on transthoracic echo with their probes are not the same as what we have for TE. It's a higher frequency, as you know, and higher frequency is not the resonant frequency of the size of the microbubbles that we use routinely in clinical practice. And because of that, you don't have that nice signal to noise ratio that you get with transthoracic echo contrast. And with TE, it's less homogeneous. You don't get that tissue suppression as well with the transthoracic imaging. And sometimes it's difficult to get that full opacification. You don't really drop that MI down. Here it's 0.18 as shown here. But then this is a good example where you can actually see full opacification here in the long axis and here in the short axis, side-by-side view, non-contrast, contrast, and this is an artifact. Here's probably the best example of contrast to short thrombus in the left atrial appendage. This is a patient with atrial fibrillation, and you can see that there's spontaneous contrast in the left atrial appendage. So this is spontaneous echo contrast or smoke in the left atrial appendage. Sometimes we'll refer to this as a sludge within the left atrial appendage. Trying to use color Doppler with decreased scale to see whether or not it fills fully there. So the big question is, can you go ahead with cardioversion or not? Because of the stasis that occurs here, you know it's already going to be difficult to get ultrasound-enhancing agents into the left atrial appendage. You have to really play around with the settings. You have to give enough ultrasound-enhancing agents to opacify and slowly opacify that left atrial appendage. But on top of that, you don't want to give so much that you lead to attenuation of the left atrial appendage from contrast. That's what's up. Here's a zoom view here. And if you pay close attention, actually, there's a filling defect within the left atrial appendage that doesn't fill with ultrasound-enhancing agent, and that's a nice thrombus. So there's thrombus on top of spontaneous echo contrast. So here in this patient, they decided not to go ahead with cardioversion appropriately. This is a systematic review of 3 studies that looked at contrast TE to assess the left atrial appendage pre-cardioversion. And in this systematic review of 3 studies, almost 400 patients, the use of contrast with TE reclassified about 2/3 of cases, ideally deemed to be indeterminate for left atrial appendage thrombus on non-contrast TE. And they found thrombus present in 13%, but excluded thrombus in 53%, and the remaining remained indeterminate, kind of reflecting that challenge of using ultrasound-enhancing agents with TEs and the lack of a really good contrast-specific preset. There hasn't really been that demand for vendors to focus on developing contrast-specific presets that are good for TE, because we just don't use it during TEs as often as we use it during transthoracic echocardiography. Okay, lastly, a couple of last cases, and we'll have time for lots of questions if there are any. So this is also, I showed this also at the contrast workshop at CSE 2023. So once again, apologize for any repetition for those who did attend that workshop. These are 2 cases from our lab at St. Michael's Hospital of masses, one in the left ventricle, apical 4 top left, and a zoom view here of the apical 2 chamber view, although they may not quite rotate it over. You can see this mass here that's attached to the probably distal inferior septum, distal inferior wall. Difficult to know if there's an associated wall motion abnormality or not, but it looks like it thickens well. And a second case on the right, a mass that's quite large in the right atrium here. I can't see it well on the RV and through parasternal long axis view. You can see it on the parasternal long axis, parasternal short axis view here in the right atrium. This is a modified right lateral view here. Sonographer is labeled the SBC, right atrium, IVC, left atrium. And kindly placed a nice arrow to, just in case the reader was going to miss that this was a mass. There's a little tiny arrow there. And here you can use a contrast to look at perfusion of these masses. This is the left case with contrast imaging. And here you can see the bright flash that we use to destroy microbubbles within the cavity, but also within the mass. So you can see with destruction, the immediate frames after the flash, the mass is fairly dark and then it fills slowly as it replenishes. So this mass is actually reasonably well perfused, almost has the same perfusion as the adjacent myocardium, for example, shown here. And this is a first pass of a right atrial mass, and you can see contrast injected. The SVC fills the right atrium and slowly fills that RA mass. You can see the bubble getting into this mass. So the perfusion of the mass on the left is definitely better than the perfusion of the mass on the right, but both are perfused and both ended up being cancer. The one on the left was a poorly differentiated carcinoma of the lung, and the one on the right was a Burkitt's lymphoma. So the last two slides, for those who are interested in implementing contrast within their labs, or for those labs that have contrast and want to get better of using these ultrasound-enhancing agents within their workspace. I think some of the keys to successful implementation that we've learned over time and we've been able to do here at Semitos is you got to make that commitment to reducing suboptimal poorly diagnostic studies. You got to be fed up enough that you want to make the change to improve quality. It's all about quality. Kathy, one of our sonographers, talked about quality in one of our local rounds the other day, and I think we need to strive for the best quality to optimize management of our patients. It's a better service for referring patients. It reduces unnecessary downstream testing. When we don't get a diagnostic or there's a poorly diagnostic test, guess what? It leads to another test down the road as the referring physician can get the answers that they need to know what's going on with their patient. So they order another test, and thus it could potentially be a cost savings. And as well, it leads to unnecessary repeat echocardiography because if you get to be diagnostic, it could increase echo lab efficiency, where you spend less time struggling with these difficult patients. You commit to using ultra-enhancing agents early. You shorten the non-contrast protocol, and you spend a bit more time with putting in the IV and using these ultra-enhancing agents to get the diagnostic quality studies that you need. And lastly, it's a quality indicator. It's a plus for CCN accreditation. Every time I see contrast in the labs that I review, in the case that I review, it's a plus. But you got to go beyond that. You got to use ultra-enhancing agents and use it well. Have the right settings, use VLMI, use a flash if needed, etc. And that's training, development, expertise in scanning, optimization, and interpretation. And at the very least, you need one physician, one sonographer champion, and of course, you need support from administration to commit to the cost of using the agents. Although we do have reimbursement for ultra-enhancing agents, at least for outpatients in Ontario. You need to add contrast acquisition to your standard protocol, make it a sonographer-driven protocol. Ideally, a sonographer makes the decision early during scanning. London has had implemented this look at the apical views first approach, where you can make a decision about using ultra-enhancing agents early, and then get that moving as you finish up the rest of the study, do the Dopplers, color Doppler, spectral Doppler, etc. In your lab, who puts the IV in, who injects, and for us, the sonographers put the IV in and also does ultra-enhancing agent injections as well, sometimes by themselves, sometimes with the help of a colleague. And that is an issue of certification and having that delegated act in your lab. As I mentioned, we'll focus the protocol on the color spectral Doppler, require enough 2D images to show that there's some optimal endocardial definition, to get other measurements like left atrial volumes, for example, parietal long axis dimensions, and then reduce that struggle time. Because I tell the sonographers, when I read contrast studies, I'll whip by the 2D images and wait to see the contrast images at the end. and use that save time to complete. So I'm going to stop. Chiming, happy to take any questions.
Thank you, Howard, for this very, very lovely and very comprehensive review of the echo contrast. So I have a few questions, but afraid to ask actually. In your knowledge, do you know how many percentage of labs in Ontario now, after about 10 to 15 years of the efforts of getting contrast to be used in most echo labs, how many percentage of echo lab are using echo and how many are not at this point? Do we have that data?
As you probably know, we have a CSE survey. I would say it's probably incomplete, so I don't think we know for sure, but it's less than 50%. And Ontario probably has the highest use across all provinces, I would think, because we've done it earlier. We have good reimbursement for it. But I think we still have to your point, Chiming, I think we still have a ways to go to improve the use of ultrasound-enhancing agents in our echo labs.
So the battle is half won, and we still have to go. Another question I'm always curious, and I don't really have a good answer, is how come for the artificial intelligence piece? I mean, people have worked so much on automated body detection for LV quantification, but it seems to be really hard for contrast images in artificial intelligence or machine learning and whatnot to try to figure out that border to calculate ejection fraction areas or things like that.
Yeah, no, I agree, and I think part of it is the recognition of the interface between the cavity and the myocardium, and with non-contrast imaging, the myocardium is always black. Rarely you might see spontaneous contrast in the LV if the LVEF is extremely low, and it's easier for algorithms to detect black versus any kind of shades of gray or white. But as I mentioned before, unless you create a dark myocardium with white cavity, then it's quite subjective as to what that line is. So until they can improve algorithms to know, separation between a bright cavity and a not so bright myocardium, then I think it's going to be challenging. So it's reverse of border detection with non-contrast. And I don't know enough about AI to know, what the hurdles are to allow us to do that or not.
I think a lot has to do with signal to noise in terms of finding the border. I absolutely agree. I think technology will come. I think one day soon enough this will happen. One last question for me. These are all the questions that I always wonder. And the last one is a bit more controversial. Should all stress echo use contrast?
Yeah, I think there are definitely labs that believe that and use it 100%. And personally, I actually would have no problems with 100%, in all honesty. But I think from a practical, maybe somewhat cost savings aspect, I would say no. But I think it all depends on two things: image quality, and sometimes we do get pristine image quality. Although I've talked about this before, sometimes you don't know if the image quality will be maintained in the immediate post-stress with treadmill or a peak stress with supine bike. Sometimes there's a bit of degradation of images, and it depends on the indication and the pretest probability. So for me, even with very, very good baseline images without contrast, if you're dealing with somebody with known coronary disease and has resting wall motion abnormalities, then I would say use ultrasound-enhancing agents 100% for stress echo, because you want to have the best diagnostic quality. So I would use contrast in that setting. Somebody with low pretest probability, almost so low you're not sure why you're doing a stress echo on it, and really good image quality, I'd probably say you can get away without it.
No, that's a great answer, because we do know that in certain part of the country, for example, Edmonton, they use quote unquote 100% of the cases use contrast for the stress echo. And part of the reasoning they have is because patients often have to travel quite far and they don't have a second chance to bring them back. So they're very much, all out for these kind of tests. So I'll open the floor because I've taken all the questions so far. Open the floor to other people. Any other questions?
Yeah, I have a question regarding. Can you hear me?
Yes, loud and clear.
Yeah, yeah. So the thing is, doing contrast in everybody. I know some cases you don't need it, but when you're working in a private practice and you get referrals with chest pain, family doctors do need an answer, and half of them I don't think need a stress echo. But doing just a treadmill without imaging, I think is a waste. And then if you do it without contrast, with contrast will give you a definite answer, and the cost is not that much higher. At least you can send a report back saying that everything is fine. And I personally, I feel that every patient should have a contrast.
Yeah, I don't disagree, Naresh. I don't think it's wrong to do it because it really does give you the best quality image. And particularly with treadmill, I think there's certainly more variability of the image quality in the immediate post-stress period, and you have that super short time to acquire the images. So to aim for the highest diagnostic quality, I don't think you can ever be faulted for that.